This talk has predominantly been focused on providers and pharmacists, and I know that we've got a large representation of nursing staff. What I'll try to do as I'm going through here is kind of highlight principles of practice around the management of suspected infection. These are things that I think that facilities can kind of look at as opportunities for improvement, and as I go through, I'll try to highlight those things. What I'm going to focus on, as I think I alluded to in the first talk, is the big three: pneumonia, UTI, skin and soft tissue infection, or as I refer to them as the pus infections. And then if I have time, I do want to spend some time on C. diff. You already had a talk today on C. diff. There are new guidelines out focused on treatment. So I'm not sure that I need to spend a huge amount of time on this since it was already covered this morning, but I'll try to focus on some highlights. So again, people are familiar with the UTI. It's the most common infection treated in long-term care facilities. And we spend a lot of time worried about asymptomatic bacteria, but it's also important to note that a urinary source is the most common cause of sepsis in the long-term care facility residents. So this is important to know how to treat appropriately and recognize appropriately, because this can get patients sick pretty quickly. And it's also the category of infection to spend most of our efforts in nursing homes on, because it accounts in most facilities for about half, if not 2/3 of all antibiotic prescribing, depending on what facility you're in. So if there's nothing else that you remember from this talk today, please remember that UTI is a clinical diagnosis. It is not a laboratory diagnosis. There is no magical number of organisms in the urine that indicates the presence of infection. Most individuals who have an old urinary tract system are going to have some level of inflammation in their urinary tract, rendering the urinalysis essentially unusable, with the exception of when it's normal. So the urinalysis is great when it comes back negative for bacteria or pyuria. You've largely excluded UTI if that happens, but a positive or abnormal urinalysis does not diagnose UTI, nor does greater than 100,000 of whatever organism you want to say. I've had people come up to me and say, well, what if it's E. coli? And like, it doesn't matter, okay? It's a clinical diagnosis. So please remember that. We've inoculated generations of nursing staff, pharmacists, and providers to put this great amount of trust in the urine culture, the urinalysis, as being diagnostic of a UTI, and it has no diagnostic value except to rule out UTI. So when they're negative, you've ruled out UTI. When they're positive, you haven't ruled in anything. Now, a urine culture is great for helping you make decisions about what antibiotic to put them on, but it doesn't help you make any decisions about should I start an antibiotic. Okay? Clear? All right, awesome. So with catheterized patients, this can be challenging. So remember, putting a foreign device in the bladder is going to cause inflammation. Their urinalyses will always be abnormal. If you get back a normal urinalysis on a chronically catheterized patient, somebody mixed up the samples, okay? They will always have a positive urine culture. You cannot make these people sterile, nor should that be the goal of your therapy. So if you've got a provider who keeps on ordering test of cure urine cultures, tell them to stop. They're practicing medicine that's 20 years old, okay? So test of cure urine cultures mean nothing. These people will always have bacteria in their urine, so getting a test of cure urine culture is like Don Quixote. So again, cultures can be used to guide antibiotic selection. They cannot be used to make decisions about treatment initiation. So why do we worry about treatment of asymptomatic bacteria? Well, the only thing we achieve when we treat asymptomatic bacteria is to make sure that when they do develop an actual infection, it's that much harder to treat. So we don't want to keep on chasing the dragon, so to speak, with the urine culture. And I can't tell you how often I get patients referred to my clinic because they have recurrent UTIs, and what has been happening is somebody keeps on checking a urine culture and saying, you have a UTI. I get a lot of older women referred to my clinic for management of recurrent UTI, and I ask them, how do you know when you have a UTI? Well, I only know when I go to the clinic. I'm like, oh. And what happens in the clinic? Well, they tell me I have a UTI when I send them my urine specimen. So 8 times out of 10, I'm saying you don't have recurrent UTIs. You have chronic asymptomatic bacteriuria. And these are studies now that are 20, 25 years old now showing we have no impact whatsoever on clinical outcomes when we treat asymptomatic bacteriuria. The only thing we do is make those outcomes worse because it cultivates resistant organisms. So, again, to be clear, I'm not speaking out of both sides of my mouth. We should always get a urine culture when treating a UTI in older adults. In fact, I've gone to the point now where I don't think you should be treating any UTI without a urine culture, just given the background rate of resistance. So guidelines still say we can treat based on symptoms alone without a urine culture. I think that that's probably bad practice because almost all the population-based studies show there's not a drug out there that has a resistance rate that's less than 15%, other than perhaps nitrofurantoin. So that's kind of the threshold that was set for making decisions about empiric therapy. And when none of your empiric therapies have a greater than 85% success rate, I think we should be getting urine cultures in everybody because you're going to have a failure rate, and then you want to know what to put them on when they come back with persistent symptoms. So in the nursing home, that resistance rate is well above 15%. You should always, always, always get a urine culture before starting treatment for UTI because whatever you pick empirically, you're going to have a substantial risk of getting it wrong. And so you need to know what to put them on when that culture result comes back. It's also extraordinarily useful to help make decisions. Can I put them on a more narrow spectrum drug? So having that culture result allows you to de-escalate more intelligently. So always, always get a urine culture. If you have problems with providers not getting urine cultures and just treating empirically, this is something that you should be working on as a facility to make sure that they're doing. So empiric therapy, again, this is where I think a facility-specific antibiogram can be very useful. I think it's more useful to have a syndromic antibiogram rather than a pathogen-specific antibiogram. What do I mean by that? So add up all of your urine cultures, all those organisms, and then take your 5 most common oral drugs and say what percentage of all those pathogens are susceptible to those 5 drugs. You're going to find in most cases nitrofurantoin is going to be your most predictably active drug, and you're going to find in most facilities your quinolone is going to be your least predictably active drug, which is exactly opposite of what prescribing occurs in most facilities. Most people reach for the quinolone. They don't use the nitrofurantoin. There's a lot of reasons for that because we've trained a generation of geriatricians to say nitrofurantoin is on the bears list, it's a bad drug, you shouldn't use it ever in older adults. And so de-educating them about that is a problem. So I'm a big fan of nitrofurantoin. Its problems are you can't use it if you suspect an upper tract infection, so it should only be used in lower tract or bladder infections. It can't be used in individuals whose creatinine clearance is less than 30. Okay, so advanced renal insufficiency is a population where you want to avoid it. Bactrim I like, but it does make providers a little bit irpy because one, you're going to see a bump in the creatinine. You will see a bump in the creatinine. It happens because it interferes with excretion of creatinine in the proximal tubule. So you're going to see a 25% bump in the creatinine in your older adults when you put them on this drug. That freaks people out. But as long as you know it's going to happen, and if they get above 25% their baseline creatinine, then you know you have a problem. But as long as it's below that, I don't get worried about it. But you need to know what their baseline creatinine is to use this drug effectively. It does raise potassium levels. So if you've got patients on spironolactone, potassium supplements, this can be a tough drug to use. But at the end of the day, fluoroquinolone should be kind of de-emphasized. I actually don't mind amoxicillin and cephalexin as long as I know that these drugs are active against the organism that I have in the urine. But I don't tend to use them for empiric therapy. I use nitrofurantoin or Bactrim empirically, and then once I get cultures, I'll work in the penicillins. Remember that fosfomycin is a reasonably good drug to avoid putting somebody on IV therapy. Now, this drug is not consistently active against Pseudomonas. I have used it for Pseudomonas UTIs as a way to avoid putting them on IV therapy because most of the Pseudomonas I see in the nursing home, once it gets to me, they're quinolone-resistant Pseudomonas. So you're looking at, aminoglycosides, which nobody likes to use, or you're putting them in the hospital for intravenous therapy because most of the anti-pseudomonal drugs require multi-day dosing. But fosfomycin can sometimes be an alternative. It's actually not a bad drug for some of the multi-resistant gram-negatives as well. Still not a lot of CLSI guidance on resistance cut points for this drug. So this is something that you want to work closely if you have a population with a lot of resistant gram-negatives, working with your lab and ID experts to figure out whether fosfomycin should be in your rotation is not a bad idea. Remember to always follow up on culture results, and if you started with a broad spectrum agent, so for whatever reason, I've got them on Cipro, comes back E. coli that's susceptible to amoxicillin, switch them to amoxicillin or put them on nitrofurantoin. There's no reason why you can't do that. And it's going to be a safer alternative for them. I think we prescribe for far too long. I already mentioned this. Guidelines basically say everybody in a nursing home has complicated UTI, and frankly, I think, again, this is my personal comment, so I'm not going to give this the aura of guidelines, is bunk, okay? If I have a ambulatory, otherwise stable woman in the facility who gets better in 24 to 48 hours, then I'm going 3 to 5 days with that person. I don't feel like I need to go 7, 10 days with them. Men, I tend to take out to 7 days. If you're going to be using anything other than Bactrim or a quinolone, you generally have to go 7 days. So nitrofurantoin is better with a little bit longer course of therapy. There was just a study published using 5 days of nitrofurantoin showing a slightly higher failure rate. So I tend to use a longer course of nitrofurantoin. The beta-lactams don't get into the urinary tract at the same level as those drugs, so I tend to take them out to 7 days. So there is a little bit of nuance depending on the drug that's used with duration. But in general, if you're treating a lower tract infection, there is no advantage to going beyond 7 days of therapy. If you have concern about upper tract, it certainly is justifiable to take them out to 10 to 14 days. I tend to look at clinical trajectory to dictate duration of therapy. So if my resident is getting better, I take them out 48 to 72 hours beyond clinical improvement is my approach. So I don't adhere to kind of a strict 3, 5, 7 day duration. I kind of follow clinical trajectory. And then remember, if the resident isn't getting better on antibiotic therapy, and you've got a culture saying the drug should be active, then you really need to be thinking about what else could this be. And I can't tell you how often I've had residents with pneumonia get treated for UTI because the UA was abnormal. And so we have to remember that UTI is only one of the infections that we encounter in the nursing homes. And so if they're not responding as we would expect, that's a red flag, and you need to come back and ask yourself, what else could this be? So why am I so down on quinolones? This is a carpet bomb to our microbiome. And it's very potent at wiping out the positive flora in the intestinal tract. And its effects seem to be very prolonged. This is a study that looked at microbial profile before, after, and then several months after antibiotic exposures with different agents. And what they found is, not surprisingly, all of the antibiotics had some effect on the microbial profile while people were on therapy. Nitrofurantoin had the least effect on intestinal microbial profile because it doesn't get into the intestinal tract with any appreciable levels, at least the colon, I should say. It's taken, so it's there in the intestinal tract, but it gets absorbed before it gets to the colon. The beta-lactams tend to have lesser effects. Quinolones, very profound effects. And then when you do follow-up studies and look at microbial profiles, residents' microbial profiles don't recover as quickly after a quinolone. And that seems to translate into risk for C. difficile. And this is a nice study kind of categorizing different classes of drugs as far as their risk of promoting C. difficile. And clindamycin, still the heavyweight for inducing C. diff. But if you kind of just go down a little bit, quinolones are right there as the next group of drugs in their potency for selecting for C. diff. And when you go to the left and look at tetracyclines, nitrofurantoin, very low risk of C. difficile. The non-beta-lactam, beta-lactamase inhibitor, penicillins like amoxicillin, penicillin alone, and Bactrim are still able to select for C. diff, but they don't do it as well as the broad spectrum agents. So going from those broad spectrum to narrow spectrum can benefit your residents. And then this is a more recent study just looking at empiric therapy in the emergency room setting, and they looked at relative risk of inadequate therapy. And what they were able to show is being elderly, male, and getting a quinolone were associated with discordant culture results. That's how they determined inadequate therapy. You got a urine culture, started an antibiotic empirically, and then followed up on the culture results. Giving a quinolone was one of the highest risk factors for having a bug-drug mismatch, and that's because of the high rates of quinolone resistance in nursing homes. But giving nitrofurantoin empirically had a protective effect, very low risk of bug-drug mismatch with nitrofurantoin. So that's why I don't like the quinolones. I like nitrofurantoin is because it's retained its microbial activity over years. And this is an older study now. Geez, this is getting to be almost 20 years old now. I probably need to find an updated study to put in here. But what it shows is actually over time, nitrofurantoin activity has improved over time, and that's probably because it's not used that frequently. And so whether we'll see it start going down if it becomes a more commonly prescribed medication, I think that's something we need to keep an eye on. Now, the labeling still says, I think a GFR of less than 60 is still shouldn't, 30 now, they changed the label. Oh, good, okay. So this is a study that showed no difference in outcomes based on renal dysfunction. Now, what you'll notice from this study is nitrofurantoin, when you compare it to Bactrim or fluoroquinolone, still is associated with a higher rate of clinical relapse. But there wasn't a higher rate of septicemia or severe adverse outcomes. So I like using nitrofurantoin, recognizing that I may have to switch to a different drug if there isn't a treatment response. I think you're going to probably see a little bit of a higher treatment failure rate with nitrofurantoin, even if it's susceptible, than you otherwise would if you had a susceptible quinolone or Bactrim isolate. But because of its side effect profile, narrow spectrum, I still like to use it as first line. So prevention of UTIs, we all know, avoid the indwelling catheter. And I think skilled nursing facilities have actually done a really nice job of getting catheters out. I'm hard pressed to find facilities where there's a lot of unnecessary catheter utilization. Again, there's no data that suprapubic catheters reduce the risk of symptomatic UTIs. So I tend not to recommend their use. You can get a lot of good urinary catheter, or I should say bladder management, with just good peri-care, straight cath, behavioral prompting. It does require a lot of investment in nursing resources to do this well, but it's a good way to avoid the catheter. There's kind of mixed data on whether intrauterine estrogen is beneficial. I've used it in older women who had no history of UTIs, and then they become postmenopausal and all of a sudden start getting UTI after UTI. So not really applicable to the nursing home. There is no data that prophylactic antibiotics are beneficial. In long term, most of the studies that have looked at this have had a 30-day, 60-day follow-up, which is completely inefficient to look at long-term effective antibiotics. And I think that what ends up happening is you just cultivate resistance. And if you did a 6-month, 12-month follow-up, those studies tend to show that the effectiveness of antibiotics goes away after some period of time. And so this is something where the ID docs and the urologists get into fights all the time about, and you get the dueling specialists. And I don't have great advice for you that other than refer them to an ID specialist rather than a urologist to get them off that chronic antibiotic therapy. There was just a study that was published by Jithani Mehta, which showed that cranberry tablets are not effective in the nursing home population. I still use them very occasionally in women who clearly have recurrent E. coli UTI. The proanthocyanin does seem to interfere with the P. pili adherence to the uroepithelium, but I will say in the nursing home population, doesn't seem to be that effective. So I think it's largely a placebo in this population. And then I do use methenamine quite a bit, and if you have somebody who's intermittent straight cath or an indwelling catheter, bladder installation of acetic acid can be very beneficial for people who have clear-cut recurrent UTIs. And so somebody who's ended up in the hospital multiple times with urosepsis, looking at some way to prevent recurrent UTIs, I think is worthwhile, and getting them referred to a specialist is a worthy activity. And I do these things, although there's still not a lot of good evidence to support their use. And if you look at the CAUTI prevention guidelines, they basically say there's no evidence to support the use of methenamine or intrabladder installation of acetic acid. So those are my qualifiers. Okay, respiratory tract infections. So these are the conditions that often trigger a lot of antibiotic use, both in the community and nursing home. The vast majority of these are viral in nature and not bacterial in nature, so we shouldn't be treating these with antibiotics. And the data is pretty unequivocal. Despite this message going out, we continue to prescribe for these conditions a lot. All I can say is stop doing that. I'm going to talk a little bit about some of the choices here. So if you're going to use an antibiotic for a respiratory tract infection, if I was just to query the audience, what's the antibiotic that most providers reach for? What's that? Okay, that's one. I was hoping for a different answer. Okay, I heard it. Z-Pak, azithromycin. You will be surprised to see that 40 to 50% of all pneumococci, the #1 bacterial cause of respiratory tract infections, are resistant to macrolides. You should never, ever be using macrolide monotherapy for a respiratory tract infection, because you need to be treating pneumococci if you're treating a respiratory tract infection. So if your provider is reaching for the Z-Pak, they're using that drug for its anti-inflammatory and mucolytic properties, not its antibacterial properties. And they're most likely treating a viral infection. So that's why people get better with Z-Pak. So azithromycin has systemic anti-inflammatory properties. It does seem to enhance mucus clearance in the respiratory tract. So it has some antibacterial activities which are probably providing some symptomatic relief. But I'm a strong believer we shouldn't be using antibiotics for symptomatic relief. We should be using for the antimicrobial properties. So rhinosinusitis, 90% are viral. Purulence does not equal bacteria. Everybody who gets a upper respiratory tract viral infection will develop purulence at about the second week of their illness. So I can't tell you how often. I think I have a bacterial sinus infection because my snot turned from yellow to green. Well, that's going to happen in the vast majority of people. So purulence does not equal a bacterial infection. So the people you want to reserve infection for are for severe presentations. So fever, localizing symptoms, they clearly are wiped out by this infection. Or double sickening. So they get a viral process, they have sore throat, they've got cough, nasal congestion, they seem to be getting better, and all of a sudden, boom, they get hit again. So the virus kind of primes for a bacterial infection, so that double sickening is something you should be aware of, and that is a scenario where I have a low threshold to treat empirically with antibiotics. If I have somebody getting better and then all of a sudden sick again, that worries me for a secondary bacterial infection. Acute bronchitis, 100% are viral. If you have more than one geographic location in the upper respiratory tract involved, so if they've got cough and nasal discharge, that's a virus. It's not a bacterial process. Bacterial processes don't cause rhinorrhea. So that can be a good kind of trigger. If you've got multiple geographic regions in the upper respiratory tract involved, that's a virus, not a bacteria. And again, the other thing that I tell people is expect these illnesses to go on for weeks. So it generally takes 3 to 4 weeks for people to kind of clear their symptom complex from an upper respiratory tract infection. They are going to continue to be congested. They are going to continue to have some secretions. So setting those expectations up front often tempers expectations for antibiotics when they still feel like they're bringing stuff up, week 2, week 3 of the illness. Pharyngitis, group A strep, an uncommon cause of sore throat once you get into adulthood. Even if it is there, it really has a modest impact on outcomes, reduces duration of symptoms 1 to 2 days. You generally want to reserve testing to those patients who have multiple Centaur criteria. So this is unilateral pharyngitis, adenopathy, absence of rhinorrhea. Those things, if you've got multiple kind of Centaur criteria, then it's appropriate to test. And this is not really appropriate for this population, but in the 15 to 25-year-old, somebody who's coming in with what looks like strep throat, they look like crap, they've got a bad pharynx, and they look toxic appearing, and the strep test is negative, think Fusobacterium. So chronic bronchitis, probably the one that we encounter the most in the nursing homes. And the thing to remember is the likelihood of a bacterial infection is largely dependent on the severity of the underlying COPD. So individuals who have mild to moderate airway obstruction, they may get exacerbations, but those exacerbations are almost always viral in nature. And if they're not sick enough to go to the hospital, generally they don't need to be on antibiotics. So I reserve antibiotic therapy for those who have advanced airway obstruction or they look sick enough that I would consider putting them in the hospital. Those are people who should get antibiotics. In general, the primary therapy for these people is bronchodilators and systemic anti-inflammatories. And I can't tell you how many times I've been consulted on a patient for, a bad COPD, and they're like, they're not getting better. I've done all these antibiotics. What else can I put them on? And they're not getting prednisone first. And I'm like, Well, you're not treating their underlying airway obstruction. You got to treat those things first. The antibiotics are adjunctive with severe airway obstruction and those with severe presentations. I think procalcitonin might have a role here. This biomarker has not been well studied in the nursing home population. Dan alluded to this in his talk earlier today. There are nice studies showing that procalcitonin can help distinguish acute exacerbations of chronic bronchitis that are more likely to be viral versus bacterial in the ED setting. That's kind of all age groups. I haven't seen a study that is kind of focused on just nursing home populations, so I'm a little bit conservative, and I tend to still rely on how sick the patient looks rather than what the procalcitonin is telling me. But if you've got a high procalc in somebody with underlying COPD coming in with a respiratory presentation, that's probably somebody who would benefit from antibiotic therapy. And if they have a low procalc and they're kind of, yeah, let's give them a day or two of bronchodilators and prednisone before pulling the trigger on antibiotic. That kind of has been my approach with those patients. Okay. So this is a study that I think needs to be reproduced. And by that I mean needs to be reproduced in the nursing home population. So again, this is an outpatient study looking at the role of delayed antibiotic scripts. So trying to get providers to not treat up front, but give a script to the patient and say, fill this if you're not feeling better in 2 to 3 days. And in general, the delayed antibiotic script has been pretty effective in the outpatient setting when it's been studied. It hasn't been well studied in the nursing home, but I think it's a principle that we should consider adopting. Again, if you've got a patient who's got multiple upper respiratory tract symptoms, you think it's, you know, a viral process, there's no reason that we need to jump on that patient with an antibiotic right away if they don't have fever, their white count is normal, they otherwise are still engaging in group activities, eating. That's not a patient who needs to be on an antibiotic right away. And kind of taking a wait and see over the next several days to see if they kind of continue to perk up, I think is a worthwhile approach. All right. I've already talked about chronic bronchitis. I give you some of my recommended therapies. I like doxycycline a lot for acute exacerbations of chronic bronchitis because it has pretty low C. diff risk. It's generally pretty well tolerated. Very few intestinal issues for the most part. Amoxiclav, I think, is another reasonable choice, but about 10% will have significant diarrhea due to the clavulinate. So I tend to use that as a second line drug for that reason. Pneumonia, I've already said, never treat pneumonia with macrolide monotherapy. Consider the possibility of aspiration. And again, what you're treating with an acute aspiration is what was in the oropharynx. And so we were kind of taught in medical school that if you have aspiration pneumonia, you got to have an anaerobic drug on board. And I just don't think the literature supports that at this point. The key thing being what usually gets people into trouble is not treating bacteria in the lower respiratory tract for a few days. So normally what gets aspirated are the streptococci in the mouth. If they're in a nursing home or a hospital, they've got gram-negatives in their mouth that go down in the respiratory tract. Those create an anaerobic environment, and then the anaerobes thrive generally after 48 hours. So if you're getting somebody with an acute aspiration, just treating strep and gram-negatives is probably all you need. And so I actually like ceftriaxone as an initial therapy for acute aspiration. I don't think they need to be on pip/tazo or cefepime flagyl, even though the guidelines say this is an HCAP situation. And then if it's just plain old pneumonia and it's mild, again, I like doxycycline. It has good pneumococcal activity. It hits H. flu and it hits Moraxella. So those are the big three pathogens that you're trying to treat here. All right, skin and soft tissue infections. So, redness or presence of a wound alone are not sufficient for starting an empiric antibiotic. Just remember, antibiotics are not wound care agents, okay? So, redness does not equal cellulitis. I get a lot of referrals for refractory cellulitis. They've gotten 5 courses of antibiotics, and like, why won't they get better? And it's like, well, lift the foot up, redness goes away. They have dependent rubor. So it's very common after a bout of cellulitis to get post-infectious capillaritis or dilation of the capillaries. And what happens when they leave the hospital? They get up and walk around, and now their foot is dependent, it gets red, but they have no fever. They may complain that their leg is a little bit tight, but they don't have significant pain. Their white count is normal. If you check a CRP, it's normal. And when that redness drains out of that foot with elevation above the heart, you know that this is just a vascular phenomenon. It's not an infection phenomenon. And there's no such thing as bilateral lower extremity cellulitis, okay? So they have edema-induced thrombophlebitis if they have bilateral cellulitis. So think about non-infectious things in patients who have redness that isn't resolving with antibiotic therapy. And I've already said wound does not equal infection, so diabetic foot ulcers are extraordinarily common in this population. So you got to do the blocking and tackling before you kind of start worrying about the antibiotics. So do I have relief of the pressure that led to the wound in the first place? If I don't have that fixed, I can throw all the antibiotics I wanted in the world, they're not going to get better. Do I have arterial insufficiency? If they have arterial insufficiency, how do you expect the antibiotic to get to the wound? If they don't have any highway going to that wound, they're not gonna get better with the antibiotic. And so you gotta treat those things, and then you gotta have wound care in the right place. You gotta have those 3 parts of the puzzle addressed before we start worrying about antibiotics. Now, if they've got an angry red soft tissue around the wound is all of a sudden started draining a lot more, they've got fever, they look sick, treat the soft tissue infection, but don't keep them on an antibiotic for weeks and weeks because you're hoping it's going to accelerate wound healing. Treat them 7 days, 10 days for the acute soft tissue process, get them off the antibiotics, and address the mechanical, vascular, and wound care issues. That's where you're going to make hay with the wound. The antibiotic has no impact on healing. And you don't need to always assume that they've got osteomyelitis. So if the wound gets better with pressure offloading wound care, optimizing blood flow, and they're not on antibiotics, they don't have osteomyelitis. So not everybody needs an MRI, not everybody needs a bone biopsy. I will often get a plain film to see whether they've got periosteal reaction in the bone underneath, and then I will see how they do with optimizing all those other mechanical vascular issues. And if the wound's getting better and a follow-up x-ray shows no evolution of periosteal reaction, I've excluded a diagnosis of osteo without having to put them through an MRI. So this is a classic presentation. This patient woke up feeling kind of achy, flu-like over a period of hours, developed redness in the pretibial area that kind of spread up the inside of the leg. This is strep, and strep is the cause. This is a classic presentation for non-purulent cellulitis. This patient does not have MRSA, okay? MRSA causes pus, pustular cellulitis, or purulent cellulitis. Non-purulent cellulitis is a strep infection. Pen-VK, amoxicillin is all you need to use to treat this patient. Well, this patient might need to be in the hospital, if they're systemically toxic, and they might need a few days of IV therapy before switching to oral therapy. But you don't need them on vancomycin because this is not MRSA. And there's now a lot of studies showing that if you have a non-purulent cellulitis presentation, giving them anti-MRSA therapy doesn't confer any additional benefit on clinical outcomes. So getting your clinician, nobody taught me the difference between purulent and non-purulent cellulitis when I went through medical school. But it's critical that we make a decision. Is this a staphylococcal skin infection or more likely a streptococcal infection? Because the treatment's very different. And if I have this type of presentation, they need narrow spectrum antibiotic therapy, and the vast majority of them will get better. So if intact skin, non-purulent, it's streptococci. If there is a wound or if there's purulence, then you do need to think about staph. And in the nursing home, MRSA is present in about 25% of the residents, so you'd need to be thinking about it. Remember that we have a number of good oral agents. Bactrim, doxycycline tend to have pretty good activity. The quinolones and clindamycin have lower activity than those two agents. Linezolid has actually come off, has come onto generic, and so it's now $4 a pill. And so that is an agent that can be used to treat staph infections without having to give people IV therapy or put them in the hospital. And then non-intact skin, I'm going to tell you that what I'm telling you here is not guideline recommendation. They tell you never get wound cultures because you're going to get a bunch of junk, and that's absolutely true. But I actually find wound cultures to be valuable, again, for their negative predictive value. If I get a wound culture and there's no MRSA, no Pseudomonas in that wound, I know I don't need to cover those pathogens. Now, to get that culture, you need to debride the wound. You need to get rid of all the dead necrotic tissue. A biopsy is the best way. Nobody gets a biopsy. A wound curettage is the next best. So get it cleaned up, go to the wound base and scrape the bottom of the wound base and send that for culture. If you don't have the ability to do wound curettage, then modified Levine technique where you go in with a Q-tip, 90-degree angle, holding pressure, circular motion to express subcutaneous fluid. That's what you're trying to culture is the subcutaneous fluid. And if you don't get staph or Pseudomonas, then you don't need to treat those organisms. So I find it to be a good way to narrow a spectrum. If my wound culture comes back negative for MRSA or Pseudomonas, I can get rid of drugs to cover those pathogens. All right, recurrent cellulitis, control edema, control edema, control edema. Nobody does this. You gotta focus on the edema. You gotta maintain skin hydration and treat tinea pedis and onychomycosis. And then after you've done all of that and they're still having cellulitis, then prophylactic penicillin is a very effective therapy. This is a nice study from the UK where they did a randomized controlled trial showing in patients with treatment refractory recurrent cellulitis despite maximal medical management reduced recurrent episodes by about 50%. Obesity and chronic poorly controlled diabetes were major risk factors for penicillin failure. So know that going in with those patients that despite penicillin, you're still going to have some breakthrough cellulitis episodes. All right, new guideline just came out at the end of last year. Big changes is a focus on targeting therapy more intelligently. So Dan referred to this today. The PCR-based tests pick up a lot of colonization. So if you've got your patient on stool softeners, stop those and see whether the diarrhea gets better before sending for C. diff. Patients who are asymptomatic and somebody just sent off a stool for C. diff that comes back positive, you wouldn't treat that, okay? So the guideline is really emphasizing don't test if you don't have clear-cut symptoms of C. diff. There really weren't a whole lot of changes in infection prevention. They've got this verbiage about soap and water or alcohol is fine. I have to say I'm still a big fan of soap and water for C. diff rooms, and I require that we have enteric precautions for norovirus and C. diff that precludes the use of alcohol-based rubs. So I'm a little bit disturbed by this recommendation. I think an issue that was really welcome to see as they talked about, assessing the implementation of your cleaning protocols. Are you doing it? So if you've got norovirus, if you've got C. diff, that's a time where your ICP needs to be out on the wards talking to your environmental services team and kind of making sure that cleaning is happening appropriately. As far as duration of isolation, generally the guidelines are still 2 days after resolution of symptoms. Curtis Donsky's group at Cleveland showed that some people can continue to shed for weeks and weeks even after symptoms are gone. It's still not clear what role the asymptomatic shedders play in the spread of C. diff in the facility. And I think this is one of those situations where you have to honor, the quality of life for the resident and not keep them locked up in the room forever. Obviously, stewardship is the major intervention for controlling C. diff at a facility level. We now have multiple studies showing we can do all this enhanced cleaning, hand hygiene, and you don't budge your C. diff until you do something about antibiotic use. And quinolones seem to be the big one. Cephalosporins and beta-lactam, beta-lactamase inhibitors are kind of the next group. So I think it's a good idea for facilities to put a lot of focus on fluoroquinolone use in nursing homes. And then the other thing to keep in mind, we got a lot of PPI use in older adults, and it's not really clear that they need to be on PPIs. So reevaluating whether the residents need to be on a PPI can be another strategy to reduce risk of C. diff. All right. So I'm not going to talk about the treatment because that was touched on today. Sherwood Gorbach has got this quote, and the guidelines have largely gone away from metronidazole. It's still a pretty effective drug, so I might disagree a little bit that we should never use it for C. diff. So if cost is a big issue, you're going to have to admit them or hospitalize them. I still don't think metronidazole is a bad choice, but the guidelines clearly are de-emphasizing the utilization of metronidazole. Fidaxomicin, again, it's nice in concept because it does seem to reduce the risk of relapsing C. diff because it doesn't have a lot of fallout on the good bacteria in the intestinal tract like vanco and metronidazole can have. The problem is it's really expensive, and in order to use this drug in a cost-effective way, we really need to kind of know, is this a person who's going to relapse if I give them vancomycin, or should I be giving them fidaxomicin? We just don't have any good tools that help us really target the use of this drug. So we don't use it a whole lot in Wisconsin because of the cost. And it has no impact on primary response rates. It's not superior to vancomycin for primary response rate. Its main value is preventing relapse. And if you've got an older adult who's had 5 courses of antibiotics, you've wiped out all their good bacteria, and fidaxomicin isn't going to help them that much. At least that's been my perspective. And then, here's the risk factors for recurrent CDI. And every one of our residents in our nursing home has these risk factors. So what I would say is if your resident is on their second episode of C. diff, think about getting them to a specialist at that point. And certainly if they're on their third episode of C. diff, because the main thing that you want to do is consider whether they'll be a fecal microbiota transplant patient. And this works very well. Brown gold, as some people refer to it. And you never see studies this small anymore. But this was a study of 29 patients that reached statistical significance between placebo and fecal microbiota transplant. This is like penicillin, versus nothing type therapy, and this can be very effective. The guidelines probably have changed a little bit towards earlier referral for fecal microbiota transplant. So first recurrence, go ahead and treat. Second recurrence, I think you want to be thinking about getting them to a specialist because they're at a high likelihood of kind of continuing this cycle. And I'm going to stop there. Thank you, guys.